Hello, everyone. Welcome to the ISOP Nigeria bi-monthly webinar, part of the ISOP Nigeria Knowledge Update series. For those who have been following us, this is our 24th session. All of us know that cannabis is the most widely used drug globally, particularly among adolescents. And research suggests it may serve as a gateway to other substances. The increasing use of cannabis raises concerns about its potential adverse effects. Today, we'll be discussing an important topic: cannabis use disorder, changing trends, and treatment approaches. My name is Ejikeme McBishop Sogweji, the head of ISOP Nigeria webinar team. And joining me, moderating today's panel, is Dr. Martin Agwoge, the president of ISOP Nigeria chapter. Before introducing our speaker, I'd like to clarify that the views expressed during this webinar represent the speaker's perspectives and not those of ISOP Nigeria. This is not medical or treatment advice. There will be an opportunity to ask questions during the seminar, so please feel free to use the chat box to submit your questions as the presentation progresses. We will address them after the talk. Now, it is my pleasure to introduce today's speaker, Dr. Ernest Anaba, who brings an impressive background to this discussion. Dr. Anaba is a certified addiction medicine physician and clinical director of Resurgence Recovery Center. He is a diplomate of the International Society of Addiction Medicine, ISAM, and an international co-occurring gambling specialist. In the last 8 years, Dr. Anaba has made valuable contributions to improving the addiction healthcare system for diverse population in Nigeria. As the Chief Medical Officer at GetCare Africa, he leverages clinical expertise to develop innovative technological solutions for addiction treatment. He serves as the country representative for Smart Recovery International, SRI, which has supported hundreds of individuals in recovery from drugs and behavioral addictions. Dr. Anaba's impact extends globally. He leads research projects and committee initiatives for ISAM's new professional exploration, training, and education. He develops telemedicine protocols for medication for opioid use disorder, TMOUD, as part of ISAM's Global Expert Network. He also serves on the Anti-Racism, Diversity, Equity, and Inclusion Committee at the American College of Academic Addiction Medicine at Johns Hopkins Bloomberg School of Public Health. He is a Center Scholar for Drug Safety and Effectiveness. He was recognized by the American Academy of Healthcare in Addictive Disorders as the first physician from Nigeria to earn a Certified Addiction Specialist, CAS certification. This underscores his years of dedicated service and commitment to transforming the addiction treatment landscape in his region. It's our pleasure to have Dr. Ernest Anaba on this platform today. So, Doc, you're welcome.
Thank you very much. Thank you so much. Thank you so much, Mr. Ejikeme. I really appreciate it. Thanks for having me. So we'll just jump right into our presentation. I will be talking on cannabis use disorder, changing trends and treatment approaches. So I have no disclosures, neither do I own any stock of cannabis products. All right, so the objectives of this presentation, we are going to be understanding more about the prevalence and the trends of cannabis use. It's going to not only be focused locally, but also globally. We are also going to understand, the short-term and long-term health effects of cannabis use. we should be able to identify the diagnostic criteria.
Sorry to interrupt you, Dr. Anaba. Ejikeme, please confirm. It looks like we are not seeing Dr. Anaba's screen. Are you sharing already? I'm not sure.
Yeah, I'm sharing already.
Ejikeme, please. Okay. Ejikeme, please. Okay, good. Now we can. Now I can see it. Okay, fine. Please go ahead. Thank you.
Okay, so thank you. Sorry about that. All right. So just to go back, I'll be speaking on cannabis use disorder, changing trends and treatment approaches. And I have no financial disclosures, or do I own any stock of cannabis products? So the objectives of this webinar, hopefully by the end of this webinar, we should understand the prevalence and the trends of cannabis use, not limited to our local context, but also globally. We should also be able to outline short-term and the long-term health effects of cannabis use. We should also be able to know more about the diagnostic criteria for cannabis use disorder according to the DSM-5 ICD-11. And we should be able to describe evidence-based treatment options for cannabis use disorder, including behavioral therapies. Now, I think as much as possible, I don't want to say a lot of technical jargons. And at the same time, I want this session to be kind of like, interactive, so we can all, be able to have something to take home, at the same time contribute. I know this is a sensitive topic for many people, which has stirred a lot of, controversial discussions. People have different opinions about cannabis use, but hopefully, I think we are not going to delve much into that aspect, of the controversial context of cannabis, but rather more of the facts and how we can also, gain more understanding about cannabis use and how it affects our patient population, and hopefully we can be informed better on how to treat. All right, so cannabis use in numbers. As we all know, cannabis grows everywhere. It's nearly in every country in the world. Yeah, and the last study that was conducted in 2016, although also still reported in 2018, was that cannabis had an estimated prevalence of 192 million people globally. So we have about 192 million people within the age of 15 to 64 years who have at least had used cannabis at some point in their lives. Another thing we need to really know about cannabis use is that it's highly predominant around the West and Central African regions. Following West and Central Africa, you could find it too in North America, then Oceania, and least prevalent is in East and Southeast Asia, as well as Southeastern Europe. Caribbean is just about 2.2%, and Central America 2.8%. Now, what is marijuana? It's a plant, right? It's a plant, and we have two species of cannabis that do exist. So we talk about indica, we talk about sativa, but what are the differences? And I think for providers on this call, I'm sure some of you may have come across some of your patients, or maybe you have loved ones, or you have friends, who use cannabis, and some tell you, oh, it makes me feel relaxed. Some people could tell you, oh, it helps me to focus, it keeps me stimulated. Now, this shows, the variety of species that are available, in the market. Indica is notably known for being more sedating, so it keeps them more relaxed. It could make them have, better sleep, right? And sativa, on the other hand, is more stimulating. It keeps them more focused, more alert, if they have to maybe probably do some work, or attend to some certain obligations, this might give them that desirable effect. However, I think it's important we know, due to the changing trends, of cannabis supplies that we have now, it's more of a hybrid form that is out there right now. So we cannot exclusively say, okay, this is just solely symptoms that could be associated with indica, or this is solely just, symptoms that could be associated with sativa due to the hybrid crossbreeding of marijuana production. I think it's always a mix right now that we do have. And I think it's important we know that cannabis contains so many chemicals. I'm sure some of us might be aware of THC, Delta 9 THC. We hear of that sometimes. Some people talk about cannabidiol. These are like chemicals that are being composed within cannabis. So cannabis have varieties, flavonoids, terpenoids, almost over 150 chemicals. So it's really an interesting plant. Now, what are the facts we need to know about cannabis? It's the world's most commonly used controlled substance. So permit me for the worldwide that you find here, because that's more like a tautology. Yeah, but it is the world's most commonly used controlled substance. And when it comes with the psychoactive substance, it should come as the third, following alcohol and tobacco. But when it comes with illicit drugs out there, cannabis ranks number 1. It is highly lipophilic. Yeah, and when I say lipophilic, it means that it can easily, it could easily dissolve in fat, in fatty tissues. So sometimes when people ingest cannabis or they smoke cannabis, most times it could be deposited, within the fat cells. And now, what is the implication of this? With fat cells, most times you might find, cannabis in people's urine, for long periods. I've found, I've been in a situation whereby I had a patient who was in recovery and he tested positive to cannabis. I think this was even after like 3 months. And this was someone who was really committed, to his treatment. But, at that particular event, I needed to also, probe further. And I understood that he engaged in a lot of physical activities. He had to go to the gym, so due to that, there was a breakdown of some of his fatty tissues. And sometimes those cells that were stored for a long time could still come up, and show up in their urine. So I think it's something, we all as providers should really take note of. Cannabis is highly lipophilic, so it could easily dissolve in fat tissues, and it could stay there for a very long time. So it's important we know that. So this is why, the following statement there, agrees with the fact that in body fluids, you could have it for extended periods of time, and which could even go beyond a month. And of course, we know it depends on several factors. So it's not just dependent on, okay, the person used it, one time, single event, single exposure, and you expect it for a long time. Of course, we're talking about someone who must have used it problematically, who might have used it for long periods of time, used, heavy amounts daily. There's a tendency for them to have this kind of experience. And it's also important we know that there are higher rates of mental illness and suicide attempts when people use cannabis. And I think this relationship is bidirectional. Yes, and I think there's sufficient evidence out there in the literature, that suggests how people who have mental health conditions, are more at a higher risk to indulge in cannabis, and also people who use cannabis have a higher risk, of developing mental conditions. So I think it's bidirectional. And the gateway drug phenomenon, yes, I think it's not only limited to mental health conditions. We can also find it within other substance use disorders. Most times, I'm sure many of us may agree that we tend to see more of poly substance use than mono, right? So it replicates in cannabis as well. You find people who use cannabis, having more tendency to use other substances, and also people using other substances having more tendency to use cannabis. Yeah, and we cannot take away the gateway drug. About 74% of people who use cannabis tend to use another psychoactive drug. Now, this is an image, showing us the distribution of cannabis receptors in the brain. Now, this is very interesting because some of us might think cannabis is just cannabis and it's just one exogenous product or a plant that people just use. Sorry. So let's clarify that, so within the body, we all have what we call an endocannabinoid system. So we all have like a cannabis system in our bodies. There are already receptors that, promote and mediate a lot of functions that are also necessary for survival. I think it's important we all know that. And now, so it's almost similar to like opioids, right? So we know there's already like an endogenous, opioid system in our body. So when you take the exogenous one, it just tends to do what? To like amplify that effect or amplify the functions of the natural one that is existent in our bodies, right? So it's the same now with cannabis. With cannabis, we have like the endocannabinoid system. And now we have two fundamental receptors called the CB1 and the CB2, right? Now the CB1 is predominantly located centrally. So when we talk about the brain, we talk about our nervous system. Now the CB1 receptor is active in that part. And I think that is what is more concerning to us and is more important for the work we do, because that is the area that is also implicated in the addictive process. Now CB2, which is the blue receptors here, the blue dots you can find, are located peripherally. Now within this peripheral nervous system, that's where you have your immune function, most of the immune responses, anti-inflammatory effects, analgesic effects, anticonvulsant effects. Now all these are mediated by the CB2 receptors. So I think it's important we know that CB1 is central, CB2 is peripheral, meaning it's away from the central, right? And so when cannabis gets into our system, they bind to all these receptors that now eventually creates those symptoms and the phenomenology around cannabis effects. So let's go to our next slide. Now this is the endocannabinoid system, and it's very interesting because it helps us to know how ubiquitous cannabis is even within our bodies, right? It has multiple functions, and I have to state this because sometimes people are like, oh, why do we find some countries trying to legalize or not legalize now? So the thing sometimes with science is when there is some form of benefits that is being identified with a certain chemical, with a certain substance. So most times it wants to be, there's need for further studies to see, okay, could this prove or show some benefits to certain conditions. So that is why you find some of these dynamics going on in other parts of the world. And from this diagram we can see the locations of some of the cannabis receptors. Now, why is this very important? Now you can see that some of this some of these parts of the brain are responsible for very important functions. Pain, very important for survival. Immunomodulation, very important. Sedation, very important. Our motor reflexes, our cognition, our memory, appetite, all these things are important. And this is why most times when people use cannabis for a long time, and with exogenous usage of cannabis, there is over time an alteration, because most times what happens in the brain is that the individual isn't allowing the body to function optimally, to function normally, because these processes should go on without external influences. So when you are taking something externally and you are now amplifying the effects, amplifying the processes, it tends to cause what we call, a neuroadaptation. So your body now starts changing, from needing, from functioning optimally at a certain level to now a way higher level. And now when it goes to that way higher level, it gets to a point that, it becomes overwhelming and it can't really function the way it should function. And now what happens is that these organs or these particular areas within the brain that mediate some of these functions, they are now altered. And now you now find the person struggling. For instance, if they don't even have to take it, they start having maybe probably sleep issues, maybe they're not thinking properly, maybe they're having memory issues, not being able to maybe remember or recall events. Sometimes I'm sure that is very common among our patient population. You find some of them complaining about their appetite, that, oh, probably they can't eat anymore, so the hypothalamus too has been affected, right? So these are some of the the thoughts that we need to connect together that explains why we witness some of this feedback from our patient population. And this goes further to just show us some of these parts in the brain, and what particularly they do. And these are the functions that could be altered when people use cannabis problematically. Okay, so let's go to cannabis use and the trend. I think this is very, very important. I think for me, it's a very sensitive discussion, yes, because I know for a fact from many providers, in this meeting, you may have come across a lot of cannabis use, and not just cannabis use, synthetic cannabis, right? Now we can see that THC percentage, within a cannabis supply, it's really important. And why is it really important? THC is the primary psychoactive chemical. So in essence, what I'm trying to say is when people take cannabis and they feel that euphoric effect, they feel reinforced to continue using cannabis, THC, which is one of the chemicals out of the so many chemicals, it is that chemical that mediates that function. So THC mediates anything that has to do with the psychoactive properties that are associated with cannabis. But here is the problem. Now, many years ago, back in the 1960s, we have market supplies that are less than about 2%. But in recent times, there's been like a dramatic increase of the THC composition in cannabis supplies. So right now you could have, on the average, maybe about 16%. Of course, you can have way higher. That's why I said on the average. So it's important we understand these trends. And this has come to, bear because many of the suppliers have, they began to formulate cannabis synthetically. So they try to, find ways to make sure that the cannabis is not just natural. They try to see how they can alter the composition of the chemicals within cannabis so that they have more potent strains. And you might find people. So I think the analogy that was given was you would need about 15 joints. So how will I put it now? So what 15 joints of cannabis would give you in 1960 is what one joint will give you now. So that should explain, the trend and what has really changed over time and how it has also affected our patient population. So 15 joints of 1960 marijuana would achieve just a joint of marijuana today. So that's really sad. And I'm sure some of you may have heard of, Colorado in Nigeria, and Colorado is more or less a synthetic cannabis. It's highly more potent, although studies are limited about the composition of Colorado, and as well, we don't know much about the market, but we know when people take Colorado, particularly for those who maybe take minute amounts of cannabis, they have more profound effects when they use Colorado. All right, so this is just explaining a graph illustrating what I said earlier. Back in 1975, you could see how low THC was, about less than 2%. Yeah, and you can see the dramatic increase from 1995 to 2015, you know, about 212% increase in THC content, which has even gone way higher as we speak. And now the average goes 16%, and some goes above 20%. So I think this is important for us to know. Now, what's another changing trend we need to be aware of? In the United States, FDA received reports about, I think, 22 patients who consumed what we call Delta 8 THC. Now, Delta 8 THC is another form of chemical, right? So Delta 9 THC is the THC we all know. That's the common one we are aware of. Now, Delta 8 THC is still one of those chemicals that have been formulated synthetically, right, to also, you know, give users more profound experiences. So I think sometime in 2020, FDA received reports, and it came out that, oh, there were about, you know, 22 patients who consumed this product, which was sold. And, you know, within the United States, you have some states that have approved marijuana use, you know, it's legalized. So for that reason, you find some people sell it as brownies, sell it as gummies. And of course, you know, while doing that, what they have at the back of their mind, the consumers they have at the back of their minds are adolescents. So they formulate it in this way, but also try to change the composition. Since it's been regulated that you shouldn't have probably more than 0.9, more than 0.3% of THC in any cannabis product, they've tried to, you know, to alter the chemical structure by adding more chemicals to CBD, formulating out Delta 8 THC. And of course, it's more or less like them trying to beat the system. So there's really no policy that is stated on regulation for Delta 8 THC. So why don't we, you know, make a switch? Why they're trying to regulate this? And sometimes this is just some of the considerations that should be given sometimes when we regulate. So yeah, and this Delta 8 THC has also shown similar, you know, effects, such as vomiting, hallucinations, you know, loss of consciousness. Sometime in 2021, there was also another event, about 661 exposure cases of Delta 8 THC, and they were predominantly children, adolescents, you know, under the age of 18, and you know, about 18% of them required hospitalization. Even some of them had to be admitted into the ICU. And why is Delta 8 THC more dangerous than Delta 9? You know, because as I said earlier, understanding that the regulation is on Delta 9 THC, the regulation is on that. So there is like a paradigm shift, people trying to see how they can alter the chemical structure, you know, of cannabis supplies out there in the market. So, and it could be marketed as something that is, you know, a milder form, you know, but meanwhile, you know, the reverse is the case. And how is it formulated? As I said, you know, it involves adding a lot of harmful chemicals to create the concentrations of Delta 8. So more or less what is done with Delta 8 THC is that CBD, which is cannabidiol, is another chemical in cannabis. Now it is altered because they add some other harmful chemicals. I learned they had discovered like lead, they've discovered like I've forgotten other chemicals too found, but these chemicals are potentially harmful, right? And they alter the chemical structure, and they form the Delta 8 THC, which they sell. Now, this is a slide showing us some of the effects of cannabis, which I think is incredibly important for us as providers, and we need to understand what are these effects, who are the at-risk population, what can we do to address these issues. So as we can see, it was a large longitudinal study from Australia and New Zealand. And what did this study show us? As we can see, with increasing quantity of cannabis use, we can see that there was a greater odds of not completing high school. So there was a greater risk of adolescents, that was, I think, particularly people or individuals under the age of 17. So for those who had used cannabis before the age of 18, they had a higher risk of not completing their high school. Similarly, if you see in the graph below that, degree attainment too was affected with increasing cannabis use. As you can see, this particular point shows for those who use less than monthly, for those who use more than monthly, for those who use weekly or more, for those who use daily. So you can see with increasing frequency, increasing intensity of use, there was an affectation on high school completion and degree attainment. Now, why is this so? It's important we understand that the adolescent brain is undergoing development. I think that's really important. We all know that. And that is why, I'm sure for some of us who are prevention practitioners on this call, we target this population because we understand that they are developmentally primed to use drugs. The way they experience the rewarding effect of substances is relatively different from the way an adult would. So you can find an adolescent engage in something that is reinforcing, and they tend to, to have or seek it to, to extreme measures, because why? The effects are highly profound. And for some substances, they even tend not to have the adverse effects, those effects that might affect, those effects that would not help make an individual, to return back to that behavior. They tend not to have most of those downside effects. So these are some of, the important details we need to understand about this particular population. And from this slide, we can see that cannabis exposure during adolescence adversely impacts synaptic pruning and white matter development. Now, synaptic pruning and white matter development are important processes. They are very important, fundamentally important processes in brain development. With synaptic pruning, once it's breached, once it's altered, once it's affected, it tends to affect their cognitive functioning. They can't think properly, they're not able to concentrate well, so they are not able to focus. And most times when some of these attributes are affected, learning cannot even take place, right? White matter development is also incredibly important in the frontal cortex development. And so the frontal cortex, some of us might know that, the frontal cortex is the reason why we are here today, right? That is the part of the brain that tells us, oh, you have a meeting now, you need to attend that meeting. No, I can suspend my the cinema or the visit I intend to do now because I have something really important to finish. Now that part does not fully develop till about 24, 25 years of age. And that's the only part that can, literally put the reward system of the brain, under some checks and balances. Now that part is also required when, with it for that part to also form, you need the white matter to develop optimally. And so when the white matter doesn't develop optimally, it also affects, and contributes to the emergence of an addiction. So it's really important we understand why, the adolescent population are adversely impacted by cannabis use. And prolonged cannabis use during adolescence will result, in a disruption of these important processes for brain development. This was just a graph showing us, the relationship between cannabis use and schizophrenia. As we can see, with early initiation of cannabis use, right? So the greater the risk of developing schizophrenia. I think this has been unanimously agreed in several literature out there. So many literatures have backed this particular, relationship between early onset of use of cannabis and schizophrenia, which we know, is a disabling psychiatric disorder, that could really impact in the functioning of any individual. Now, more importantly is why we all need to also think prevention, because with early exposure of these adolescents, there's a tendency for them to develop disabling psychiatric disorders like schizophrenia. Now, this is another slide showing us, the genetic underpinnings in addiction as well as psychosis. And so sometimes, because we also don't know our genetic makeup, we don't know if we have genes that could predispose us, to psychotic disorders. Now, this is a study showing us that, hey, there's what we call the AKT1 gene. And with the AKT1 gene, there are variants of it. There's the AKT1 TT, there's the AKT1 CT, and there's the AKT1 CC sequence. Now, with the AKT1 CC sequence, you can definitely see how using cannabis every day, could increase the risk of developing schizophrenia. And not just increasing that risk, increasing it by 7 odds. So there are 7 times greater odds of people with this particular sequence of gene developing schizophrenia. And sometimes when people use cannabis, they don't, necessarily know, what type of gene do I have, right? I think sometimes this is also what has led to the emergence of, a lot of pharmacogenomic genetic studies. Yeah, very expensive, but sometimes if people know, the type of genes, they do have, that can also be a preventive measure, to guide them on what they need to avoid, particularly even when they are at higher risk of developing certain conditions. This is another gene variant as well, called the COMT gene, COMT gene. Now the COMT gene to show the sequence similar to the AKT1 for the sequence of the valine one, the genotype of valine, you can see the greater risk of schizophreniform disorders that could be developed. And this is why most times with adolescents, some of them, when they use early, you might find long-term, mental health disorder emerging. I'm sure this is something that is common to many of us and we are familiar with. Dunedin study. This was a study, another longitudinal one. They were followed from birth to about 38 years of life, about 1,037 individuals, and they wanted to investigate the relationship between cannabis use and the neuropsychological function of an individual. So at certain points during this longitudinal study, they tried to, ascertain the outcomes at the age of 18, at the age of 21, at the age of 26, at the age of 32, at the age of 38. And they realized that persistent cannabis use was significantly associated with a neuropsychological decline. So this was one powerful study that informed the industry about how adverse cannabis could be on the brain cells, affecting the neuropsychological function of an individual. Now, screening is very important, and I think it's something that should be our watchword. It should be our best practice. beyond just knowing what is obtainable and what is happening out there and what emerging trends are, how often do we screen this patient population, regardless of whether they come in with either, other forms of, psychoactive substances? Do we screen for THC, or do we wait till we find THC in our drug test before we screen? And one thing I like with the United States, because they have a preventive service task force, that focuses on, recommendations, preventive interventions. What can we do to at least salvage people before things progress, to a full-blown disease state that becomes more, overwhelming, could cost a lot, in the healthcare space, could also create a lot of disabilities and also be associated with some, mortality risk. So what is the recommendation? We are meant to screen, all adults, we're meant to screen all adults for all forms of illicit drugs. Pregnant and postpartum women is special population we don't pay attention to sometimes. I'm sure even within the O&G space, there are limited screening for illicit drugs. Most times, I think focus is on tobacco, alcohol. Yeah, so I think it's incredibly important, we start adopting some of these practices. Adolescents, which we know are our at-risk population, it's important we screen all adolescents, regardless of what they come, they come in contact with a provider complaining about. There should always be at least a universal screening for them. It's good practice screening. Yeah, this is cannabis use disorder identification test. I don't know how many of you may be aware of this. Although there's CRAFT, which is typically used for adolescents, but cannabis use disorder identification test is also, this is a revised version. It could be administered quickly. It has good validity and reliability. A score of 8 or more is indicative of hazardous cannabis use. And this is something that can be utilized in our primary care settings. It can be utilized in our general settings. It could also detect severity of use. So I think it's something we may want to consider and adopt in practices. Now, cannabis withdrawal, this is an important phenomenon. I don't want to get into much details, but it's important we know that as long as there is no medical or psychological comorbidity, cannabis withdrawal is not fatal, right? And depending on the severity of the withdrawal, a lot of behavioral interventions can still be efficacious. And what kind of cannabis, what do you call it? What kind of behavioral interventions, like psychoeducation, coping skills training? You could reassure them. You could take them to. You could, recommend they have like cold showers. You could, reassure them, take them through like some form of motivational interviewing, therapy. Yeah, and sometimes for physicians, psychiatrists, medications could be considered. But if it's like a mild to moderate, and we are sure that there is no medical or psychiatric comorbidity involved, a lot of reassurance can really be helpful. The previous slide just walked us through some of the symptoms you should expect when people are having withdrawals, but most times these withdrawals, they could peak within a week. It all depends on the level of engagement. Sometimes some people could take it sporadically, maybe occasionally with their friends. Some people could take it daily. Some people could take it, so many joints per day, of course. So depending on the quantity, the frequency, the intensity, that would determine the severity of the withdrawals, right? So most of these withdrawals tend to peak around a week. Sometimes occasionally could persist within, for about 2 to 4 weeks, right? So it's important we know that. And sometimes when we have patients come up to us, tell us about some of these withdrawals they could have, and let me just go back there so we're just familiar with them, like irritability, anxiety, sleep difficulty, decreased appetite, depressed mood. Making them just trying to normalize it can go a long way. Make them understand it is normal. So it's just your brain trying to readjust and get back to its normal state. Mind you, while you are taking cannabis, there was a lot of adaptations going on. A lot of adjustments your brain had to go through to accommodate the quantity you were taking. So it's important you normalize it, make it normative, and try to reassure them. Yeah, and in situations where you feel they would need a higher level of care, please, you need to refer. All right, so cannabis use disorder, we're going to walk through this really fast so we don't take so much time. So as we can see, approximately about 9% of those who experiment with marijuana will become addicted. I think that's a staggering number, about 9%. So yes, we know there are people that use cannabis that will eventually get to a point that they develop a use disorder, right? But about 9% of them who experiment eventually become addicted. And mind you, don't forget an important information which I shared earlier. The earlier the onset of use, the higher or the greater the risk of developing a use disorder, of developing a mental disorder, and you can go on and on, right? So it can tell us also, can explain why sometimes, not everybody certainly, and we know there are still genetic underpinnings, right? So, but greater frequency of cannabis use increases the risk and the likelihood of developing a use disorder. This is a diagnostic criteria for cannabis use disorder. As you can see, there is, sorry, I think this slide is a bit cut. It didn't cover the entire picture. So it showed us both the DSM-5, DSM-4, ICD-10, ICD-11, just to show us, I think they are similar in different ways, right? Because they still all, they focus on, the control, the cravings, the consequences of the use, as well as their functionality, because it's very important we understand those 4 C's. Most times, when I interact with patients, I want to walk them through those 4 C's. You want to know, are they like losing control? Are they having persistent cravings, right? Are they having, do they find themselves being compelled, to engage with this substance despite having, issues with relationships, issues with their physical health, issues with their mental health, issues at work, so that already tells you, what scale, they might fall into, after you do your checks. And lastly is the consequences. All right, so treatment, and I think it's fundamentally important we know that, behavioral interventions, psychosocial interventions remains the mainstay of treatment for cannabis use. Motivational enhancement therapy, cognitive behavioral therapy, contingency management have demonstrated effectiveness in reducing both frequency and quantity of cannabis use. And I'm sure some of you on this call might have heard about, motivational enhancement therapy, talking about motivational interviewing, how it is collaborative, how it is non-judgmental, how we use an empathic approach to elicit change, right? And it is more effective for individuals who are ambivalent to change, right? And, sometimes they want to do this, but at the same time, they are doing something differently, but you want to see how you can, talk with them collaboratively and help them to identify, what is stopping them from that change and setting new goals or new recovery plans for them. So it's not really for them, but they are the ones to set it themselves. So it's not you to set it for them. So that's motivational enhancement therapy. Most times it's an empowering approach, and you just try to help and guide that patient towards that change talk and the change path. And for cognitive behavioral therapy, and from the word cognitive behavior, of course, it helps us to identify what are those maladaptive thought patterns that could also contribute to maladaptive behaviors that could also perpetuate the addiction, and how can we, cut those relationships? How can we help them, to understand the dissonance, to be able to pick up some of those negative thoughts and see how they can be more self-efficacious towards their recovery. And we have contingency management. Contingency management is built from operant conditioning, right? So it's more or less like incentivizing, a targeted behavior, right? And I would speak a little about that because I think it's one important therapy that many of us are still struggling to adopt into our practices. Contingency management is more or less like incentivizing, it could be attendance to therapy. It could be, having a normal drug test. Oh, a drug test was done and they didn't use anything. So what happens? Now, there are considerations that we need to give for contingency management to really be effective. First thing first, when incentivizing, it has to be sequential.
Yeah, thank you so much, Dr. Anaba. I think we are almost getting to our times, and we have few questions that we really like you to answer.
Okay.
Yeah, so I want to really thank you for that insightful presentation, and believe your explanations were truly valuable. Our participants have gained a great deal of practical knowledge that they can apply to their work. So we have some few questions here. Let's just see how much we can take from them. The first question is coming from Elizabeth Remy Tengia, and she is asking, so you say that today's cannabis is very strong than the past years. What makes a difference between today's cannabis and those of the years past?
Okay, thank you for that question. It's a very good question. So the recent cannabis have more composition of THC. Now, THC is the primary chemical that mediates the euphoric experiences, that mediates the rewarding effect, right? So the THC content of the former products or cannabis that we had in the market back in the 1960s, 70s are way lesser compared to what we have now. Of course, it's intentional because they suppliers already understand that, okay, yes, this is like what we need to focus on. So what they do now is that they synthetically formulate the products that are out there so that when their customers ingest or consume or smoke it, they want more, right? Because the THC composition in the recent ones are the ones that we have currently, are really high of way higher levels compared to what we had before.
Okay.
I hope that answers your question.
Yeah, I think it answers that. So we have a few other questions. The next one is coming from March Noel, and asking, how long do you usually treat cannabis use disorders with psychotherapies among adolescents and adults?
Yeah, it's a very good question. Very, very important question. Yeah, it's relative, right? It's relative. And it depends on the context of the use. Of course, with adolescents, we are more concerned because they come down with more severe presentations, right? But we cannot take away the effect of some of these treatment modalities that we've spoken about today. And it's a combination. I think the combination demonstrates better efficacy than maybe a single intervention. And when I mean combination, we have the motivational enhancement therapy, we have cognitive behavioral therapy, we have contingency management if done effectively, which is you incentivizing immediately after the targeted behavior is being achieved, and also increasing the incentives that you are giving. That incentive, mind you, has to be of value to the patient. That incentive you are giving has to be valuable. So when you do this in combination, I think from from the understanding of the treatment modalities, contingency management, and motivational enhancement therapy, they are very effective short term, but long term is cognitive behavioral therapy. So why those help in cushioning, the situation, helping the individual to, to stay true to their recovery plan and recovery goals, the cognitive behavioral therapy is what is more long lasting. So the combination of that dynamics is very great. A medication too that has shown some efficacy to a certain level, at least moderate evidence, is N-acetylcysteine. N-acetylcysteine was used for individuals below the age of 21 years, and it showed some reduction in the amount of days they engage in cannabis, as well as the quantity they use daily. So a combination of these is what I would highly recommend for adolescents.
Okay, thank you. We have so many questions flooding in. Let's see how many of them we'll be able to take. This one is from Isaiah Oyenero Aguaye. And his question is, what would be your advice as screening and treatment approaches to the comorbidity of SUD from cannabis use and mental disorders, say mood and anxiety disorders, for a better patient outcome? He said he's asking because research shows that people with anxiety, mood disorders are about twice as likely to use cannabis and vice versa.
Yeah, that's a very good question, and I completely agree with you. As I mentioned or highlighted earlier, it's a bidirectional relationship, right? So when people use cannabis, there's a greater chance or increased likelihood of them also having a mental health condition, as well as for those using mental health conditions, sometimes tend to self-medicate, and some, it's not unusual to see them, indulge in cannabis because maybe they're trying to escape that, those symptoms and the burden that comes with that condition. So my advice, first thing first, early identification is incredibly important. Adopting prevention practices is very important. Understanding when also to do an urgent referral, initiate a referral to your psychiatrist, have a multidisciplinary setup, adopt the holistic care so that you have different professionals covering different areas of treatment. I think that should be the mainstay eventually. I think it's first doing a lot of prevention programs that I would recommend, so that we even make people understand that beyond what there's this attitude or mindset that people have that cannabis is safe. Although we understand that it could have some medicinal properties and the rest. However, we cannot take away the costs too that is associated with cannabis and what it can induce, conditions that could arise, how we could also contribute to our disability numbers, right? So I think it's more of a collaborative approach that I would recommend here. Try to ensure that these conditions are identified early, ensuring that appropriate services are being offered and rendered to these individuals when they are identified, and there should also be continuity and making them to also understand how continued engagement could be effective, improving the outcomes of their treatment.
Okay, thank you so much. I think that really answers the question. Unfortunately, I'm not sure we'll be able to take the rest of the questions because we are almost at the top of the time. And I would like to bring on board Dr. Martin, if he has any final words for us.
Thank you so much, Ejikemen, for this great webinar, for the excellent moderating of this webinar. And thank you, Dr. Honest Anaba. You have done a very great job with words of knowledge in this field. I must tell you, your presentation today has brightened, the mind of people with better understanding as far as cannabis is concerned. This is really very scientific, I must say. I want to believe that the participants have actually benefited from your words of knowledge. Incidentally, we couldn't get to the end of the last slide. It was like we should have planned for a 1 hour 30 minutes webinar. You please bear with us. I want to believe that participants, we want you to come back again, to at least expand on this presentation. I think the issue of cannabis and synthetic cannabinoids is not a topic that we can actually exhaust within 1 hour because there are so many parts of it that need to be properly addressed, and there's no shortcut to it. So that we can understand very well, very well. I think, let me also add this, that when it comes to the naturally cultivated cannabis, science has also made us to understand that the potency is increasing. That is the THC in the tetrahydrocannabinol, which is the active ingredient in the cannabis, is increasing for the even naturally cultivated cannabis plant. Of course, there are other parts of cultivations with which some chemicals have been added to increase the THC. Another one is even the synthetic cannabinoid, which is not even a part of natural cultivation and so on. So all of these are different parts that we need to have good understanding of, as well as being able to differentiate, the effects each of these have as far as people who use cannabis and other compounds of it, so that when it comes to treatment intervention, at least one should be able to make these clear demarcations and differences to be able to profile adequate or appropriate treatment intervention. And above all, we do everything possible, especially in the area of prevention. So once again, I say thank you for this excellent presentation, and I really want to assure you that we'll invite you again to come and at least speak more on this topic. So to all the participants, we are really appreciative of your being part of this webinar, and please join us again soon, which will be in November for another session. So let me hand over again to Ejikeme to conclude this session. Thank you.
Okay, thank you so much, Dr. And you have always been a pillar of support to us. And I really want to thank Dr. Anaba. And just as Dr. Martin has said, we are going to have you again to finish what you have started. There are quite a lot of questions that we couldn't really touch. And I believe in our next edition, we'll be able to take care of all of them. So on this note, I want to thank all of our participants. Let the conversation continue. We hope to see you in our next webinar. Have a blessed day. Bye-bye.